if we look at the relationship between the donors and recipients, then for this particular cohort, which was 2000 to 2007, then 70% of them were from genetically related donors, 30% were from unrelated. If we look at the breakdown of that, then the majority of genetically related are sibling. There's also a substantial number of parents or offspring, so many of these are actually adult parents to their adult offspring, although some are also to children. There's also a small but increasing number, 6% there, of adult offspring to their more elderly parents, which is slightly counterintuitive and one, sometimes we're a bit uncomfortable about that, but it is increasing. A surprising number of donors in their 20s and 30s want to give to their elderly parents who have kidney failure. If we look at unrelated, then the vast majority are either spouse or partner. And most of these are, well, the majority of these are female to male for obvious reasons to the female members of the audience, not obviously to the male. And if we look at, one of the things which has driven this big increase in unrelated transplants is they do incredibly well. If you look at graph survival here for genetically related and genetically unrelated, then in fact, graph survival is marginally better for unrelated than for genetically related. Now that might be because if you give a kidney to your loved one and you're sharing the same house, you're probably going to make sure they take pretty good care of it to get to take their drugs. It's not, that's the hypothesis. But anyway, they do very well. So, HLA matching for living donor kidney transplantation doesn't seem to have any impact any longer, which is an interesting thing. So the general trend is away from HLA matching, at least in terms of graft survival. Now, probably about 80% of kidney donations in the UK from a living donor are done laparoscopically now. Almost all units now have a protocol for laparoscopic donation. And obviously the advantage are with a short hospital stay, the donor gets back to work more quickly, they have less wound pain, and they don't suffer the bulge that some patients who had the traditional approach through the loin had just due to nerve damage. There was initial concern that perhaps kidneys from taken out laparoscopically may have more urological complications. That doesn't seem to have held up. And although the pressure of the pneumoperitoneum reduces renal blood flow, it doesn't seem to have any detrimental effect on transplant outcome. And there have been several randomized controls trials. The most recently published was initially published this month, 3 or 4 days ago, by Mike Nicholson from Leicester, who did a randomized control trial of laparoscopic versus open and showed that the two primary outcome measures were analgesia post-donation and what was the other, Mike?
Hospital stay.
Hospital stay, and that was reduced by a couple of days, so quite significantly. So I'm glad you eventually got that published, actually, well done. So one of the problems if you're if you have a willing living donor is that about a quarter of living donors until recently couldn't give a kidney to their loved one or their sister, presumably loved one, because they were either blood group incompatible or they had HLA antibodies which precluded safe transplantation. And traditionally, if you do a transplant in the presence of either of those incompatibilities, then you get hyperacute rejection, the graft is damaged and irreversibly destroyed within a few hours. So it was drilled into us for years and years that always avoid ABO incompatibility and always avoid transplanting in the presence of a positive cross-match, otherwise you get hyperacute rejection. This has changed recently because there are two ways around it. One is to remove the antibodies from the sensitized recipient or the incompatible recipient, and the other is to enter a so-called pair exchange scheme, which I'll highlight briefly. So desensitization is an interesting approach, and it essentially relies on the fact that as long as you get rid of the antibodies before the kidney goes in, even if they come back afterwards, as many do, then the graft seems peculiarly resistant to further damage. There's a process of accommodation which is not very well understood, where the epithelium of the graft is resistant to antibody damage. So for living donor transplantation, this essentially means that the recipient goes through this protocol, typically lasting several weeks. This varies from centre to centre, but it typically involves depleting antibodies given several weeks before the transplant, repeated plasmapheresis to plasma freeze away immunoglobulin, starting the various transplant drugs a week or two before the transplant, and then following them up and treating antibodies in the first few days quite aggressively. And you can see this is the UK activity for HLA antibody-incompatible and ABL-incompatible transplants, and there were hardly any done until about 2003, 2004. You can see it's an exponential increase in the number of such transplants, and probably about half of all the 23 transplant units in the UK are now taking patients on for these sort of desensitization. Now, not every patient is suitable. It depends on the level of their antibodies, and it also depends on whether they're really sufficiently up for desensitization, which is quite a trying process. So not every patient is suitable. The results for ABA-incompatible transplants are really, so far as one can tell, absolutely comparable to those where there's no compatibility. For the HLA antibodies, they are a little worse than for the unsensitized patients, so the results are not quite as good. So the alternative scheme is the idea of paired donation. So we've got two pairs. Pair one is called group A to B, incompatible. Another pair somewhere else is group B to A, incompatible. And the idea is like a two-way swap. So donor from pair two gets into recipient of pair one, and vice versa. That's shown for a very simple situation where A to B and B to A. Of course, there are various combinations, and this can also be done for HLA-incompatible donors, where you find a donor that doesn't actually share the antigens to which you've got antibodies. And there are well-established schemes. The first, one of the others was in Korea. They had a very successful scheme. The Dutch have got a good scheme now. There are several sub-schemes in the US. And the UK scheme was started about 2 or 3 years ago. And essentially, transplant units find a suitable pair who want to enter this process. About 300 pairs now have been registered centrally. I'll explain to you how the central thing works in a sec. Of these, about a third have been identified to find a suitable match. Now, many of these don't proceed. About half of the ones, even with an identified match, haven't proceeded. Maybe there's problems with cross-match testing, alternative transplants come about, there are donor issues where there are problems identified late on. A third of them are removed from the scheme because they get a transplant for some other reason. And only about 15% of those who register with the scheme actually proceed and successfully get a swap. And this was only about 1.8% of the total UK transplant activity. So it is a niche. But nevertheless, for the recipients who benefit, it's obviously important. So this shows the details of the UK paired donation scheme. So the first patients were registered early in 2007. The first, it's a bit like spinning a roulette wheel, so this is done every 3 months centrally, and then all the pairs who are found to have matches are identified and notified, and the transplant units then arranged to do the transplant. The deal in the UK is that the kidneys, not the recipients, travel. The Dutch scheme is the donors travel to the recipient centre. So, the numbers of pairs registered has increased 3 month from 3 months, and the last one was done in October 2009. There were 147 pairs registered, and there you see the number of identified exchanges. Initially we started with 2-way exchanges, but then you can see we've got more adventurous and identified 3-way exchanges, so probably I think you get the idea where there's a 3-way exchange and what a scope of serious things going on with that. You can imagine. A total of 44 transplants have been done today through this scheme, but I think it will increase now. It's becoming better established. But it's probably fair to say it hasn't worked out quite as successfully as we really hoped.